Welcome everyone again to the University of New Mexico Law and Mental Health Didactic Series, weekly discussions of practice and science by experts in behavioral health and the law, hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences, along with the New Mexico Behavioral Health Services Division. We're so glad to have so many of you joining us here today. I'm Anthony Perillo, the Forensic Psychology Training Director in the Division of Forensic Behavioral Sciences at the University of New Mexico. For our talk today, if you have any questions for our presenter, make sure you ask them in the Q&A box anytime you feel comfortable. We do hold the questions till the end. We do try to get to several of them. It's not always possible for us to get to all of them, so just forgive us if we don't get to yours. If you are pursuing continuing medical education credits, there will be a sign-in sheet in the chat box shortly. The APA continuing education credit link will also be posted in the chat box, but in the latter portions of the presentation. So just keep your eye on the chat box for the information and the link for that survey. Make sure you open the link before you leave the webinar so you have that link for later, and make sure that you save your certificate after you complete the survey, because we don't have access to those CEU certifications after the fact. A recording and PowerPoint slides for this talk should be available sometime later this week. And as a heads up for next week's talk in the series, you're stuck with even more of me, because I'll be discussing procedural issues that can bias our judgment in forensic evaluations. But I'd like to pivot back to this week. I'm very excited to introduce this week's speaker, who'll be discussing mental health screening with diverse populations in correctional settings. This is Dr. Jennifer Eno Louden. Dr. Jennifer Eno Louden is an associate professor of psychology at University of Texas at El Paso, where she leads their legal psychology doctoral program. She earned her doctoral degree in psychopathology and behavior disorder from the University of California, Irvine, and a Master of Arts in clinical psychology from the University of Nevada, Las Vegas. Her research primarily focuses on the intersections of mental health and criminal justice. Her mental health and criminal justice lab at UTEP conducts research on mental illness in correctional populations, best practices in community corrections, Latinx people in the criminal legal system, and the stigma of mental illness and the criminal legal system involvement. She has also served as chair of the Corrections Committee and Professional Development of Women Committee of the American Psychology Law Society, and currently serves as an associate editor for the Journal of Criminal Justice and Behavior. I've seen her present some of her work in this realm at the American Psychology Law Society conference, and I'm really looking forward to hearing more about this myself. Jennifer, Dr. Louden, on behalf of the University of New Mexico, we're very excited to having you joining our series and thankful that you're going to be sharing your expertise with us today. I will go ahead and turn it over to you.
Great, thank you so much. Let me just make sure that I'm going. All right, so as Dr. Perillo mentioned, just a couple things about me. I started out my life thinking I wanted to be a clinical forensic psychologist, and that led me to getting my master's in clinical psych at UNLV. I then discovered that I was much more interested in doing research with correctional populations, particularly folks with serious mental illness, and that led me to earning my Ph.D. in psychology and social behavior at UC Irvine. I've been in the psychology department as a faculty member at UTEP since 2009. Anthony very succinctly wrapped up my research interests. I'll say a major focus of that is mental health in the criminal justice system, and that's what I'm going to talk with you about today. I want to just acknowledge all of my amazing students in the mental health and criminal justice lab at UTEP. Everything I do could not be done without their support and hard work. I have the instructions here for CE that I'll just kind of flash on the screen very quickly. Y'all got the instructions for the various CE evaluations and certificates and all of that. All right, I need to go through some disclosures. So just briefly, I do not have any financial arrangement about the content of this activity. I don't receive any money related to any of the things that I'm about to talk to you about today, nor does Dr. Perillo or any of the other folks who are associated with this training. I will also give you the disclaimer that the views that I'm about to express are my own and don't necessarily reflect the views of the University of New Mexico. Right, in terms of learning outcomes, there's three main things that I'm planning to cover today that hopefully an hour from now, you'll walk away with three main pieces of information. So first, I'm hoping that everyone will be able to describe the psychometric characteristics that should be considered when selecting a mental health screening tool for use in correctional settings, and we'll talk in a minute about what those are. Second, I want the audience to be able to critique the extent to which mental health screening tools have demonstrated utility with members of diverse populations within correctional settings. And then finally, to describe the clinical considerations for using mental health screens with diverse populations in correctional settings. So before I dive into all of those topics, I want to explain why this is important and hopefully why you should care about it. Mental health treatment is a constitutional right for anyone who is being held in a correctional facility. So someone who is in a jail or a prison has the right to have their healthcare needs provided by the government, and that includes mental health treatment. And this was the decision in a couple of US Supreme Court cases that are pretty long-standing by this point. And unfortunately, not everyone who enters a jail or prison gets their needs met. There was a very notorious case a couple of years ago, unfortunately, where Sandra Bland lost her life in a Texas jail cell. And part of the reason for that was not receiving adequate mental health intervention or suicide prevention. So this is a really important issue, and when we fail to attend to it, there can be really serious consequences. So that's why this is such an important area for us to think about as clinicians as well as for researchers. So let's talk about mental health screening a little bit. The American Psychiatric Association has described mental health screening as part of a quote unquote minimally adequate standard of mental health care in correctional settings, meaning that this is really the minimum that you can do in correction settings to make sure that we're meeting the needs of people who are housed in those facilities. And the purpose of mental health screening is to identify symptoms of mental illness. So whether that be anxiety, depression, psychosis, etc. It's meant to also identify acute distress, which is particularly important in jails, but it's also important in other settings as well. And finally, screening is meant to identify an individual's risk of self-harm. And again, that was very relevant in Sandra Bland's case, but it's something that for all types of correctional facilities is very important, particularly for jails, given that they're seeing people who may be in crisis. So in terms of how screening works, just to kind of follow this pretty basic diagram, on the very left-hand side, we have administration. So a screen can be administered either as a self-report or an interview by a correctional staff member to an individual, typically at intake to a facility. And whatever measure is being used will then be scored, and there will be some sort of predetermined cutoff score, meaning that someone who scores below the cutoff is thought to be unlikely to have a mental illness and would not receive any further intervention at that point. Whereas if someone scores above the cutoff on the mental health screen, it's expected that they will get some further assessment, typically by a clinician. So it's important to note that a screening tool is not meant to provide a diagnosis. It's also not meant to necessarily determine who definitely does and definitely does not have mental health problems. It's meant to instead identify people who are in need of further assessment and sort of sort those people out from the people who don't need further assessment at this point in time. Right. So now is where we get into the psychometric part of it. I won't get into any really complicated statistics, but if we think about the utility of these screens, we can think about it in terms of signal detection theory, really. So on the one hand, we have what the screening tool says. So it will either indicate that someone scores above the cutoff, meaning they need further assessment, or they're likely to have a mental health problem, or they score below the cutoff, meaning that they don't need further assessment. But as I said, this isn't meant to be diagnostic or anything, and there's some sort of true state of that person, whether that person actually does have mental illness or not. And typically that's determined by some sort of criterion. In a research setting, that criterion is usually a structured clinical interview like the SCID or something like that. In more of a real world practical setting, it's the assessment of the clinician who is in charge of that case. So the criterion will have its own determination of whether that person has mental illness or not. So there's two ways that a screen can be accurate. The first way is a true negative, meaning the person scores below the cutoff on the screening measure, and they really do not have a mental illness. So that is an accurate decision by the screen. The second way that a screen can be correct is a true positive, where someone scores above the cutoff and they actually do have a mental illness. So both of these are good in terms of evidence of the utility of that screening tool. Now, as you might have guessed, there's two ways that the screen can be incorrect. So one way the screen can be incorrect is if someone scores above the cutoff, but they actually do not have a mental illness. This is called a false positive. The other way a screen can be incorrect is someone scores below the cutoff, but they actually do have a mental illness. So we like it when our screens are correct. The two ways that the screen can be incorrect has different implications for the person being screened, as well as the facility who's conducting the screening. So if someone scores above the cutoff, meaning there's people who are false positives, this leads to agencies having to expend resources that are pretty scarce in providing further assessment to people who really do not have a mental illness. On the other hand, if a screen is producing a lot of false negatives, that means it's not doing a very good job at identifying people who have mental illness. So people who need intervention are not receiving it. So indices of utility. There's a couple of just really basic things, and those of you who are in medicine or psychology have probably heard of these before, but I'm just going to briefly cover them. So sensitivity is the probability that the tool will detect the condition when the condition is present. So in other words, it's the probability that a person with mental illness will screen in across all of the administrations of the tool, that if we have high sensitivity, then we would expect most of the people who do have mental illness would score above the cutoff. Another index is specificity. This is the probability that the tool will detect absence of the condition when the condition is not present. So in terms of overall accuracy of the tool, it means what's the probability that a person without mental illness will screen out on the tool, meaning they'll score below the cutoff. The third index is positive predictive value. This is the proportion of people who screen in who do have a mental illness. And negative predictive value is the proportion of people who screen out who do not have a mental illness. So hopefully to have this make a little bit more sense, we'll take this back to our 2x2 table that we just covered. Sensitivity is, if we're looking at the bottom row of the table, it's the proportion of true positives out of all of the people who have mental illness. So it's how sensitive the screen is in picking up mental illness. Whereas specificity is the proportion of true negatives out of all of the people who do not have mental illness. So looking at the top row of that table. On the other hand, PPV is looking at the proportion of true positives out of everybody who scored above the cutoff. So it's looking at that last column there on the right. So out of all of the people who scored above the cutoff, what is the proportion of them who are actually true positives? And then NPV is the other column where it's looking at the number of true, or the proportion of true negatives over the total number of people who scored below the cutoff on the screen. So you can see that these are all sort of complementary, and they're based on how the screen is doing in terms of these 4 possible types of decisions. So in terms of interpreting all of these values, we don't tend to see a lot of AUC statistics or things like that, where we're kind of summing up the utility of screens into one handy value. Instead, we tend to look more at sensitivity and specificity. Higher rates of sensitivity, it means that the test is identifying more people with mental illness. And we can increase the sensitivity of most tests by simply lowering the cutoff score. That's going to identify more people with mental illness. However, this comes with a trade-off. So as we increase sensitivity, we're typically doing that at the expense of specificity, meaning that we're going to get more false positives in addition to those true positives. If we're comparing tools in terms of we want to select a tool for use in our organization, it's most helpful to compare sensitivity and specificity for those tools so that we know what is the rate of identification of mental illness, but also the rate of false positives. And as I mentioned earlier, agencies have to balance increased identification of mental illness with the available resources. If a screening tool is producing so many false positives that it's taking up too many resources for further assessment, then that's going to limit the staff who are available to provide other services. In terms of the other indices, so PPV and NPV, those are most useful when interpreting individual screen results. So if I have a person in front of me and I know that they scored above cutoff on a particular measure, the PPV gives me a sense of what is the likelihood that this individual person actually has a mental illness. The other thing to know about PPV and NPV is that these are both affected by base rates. And if we went back to our 2x2 table and kind of scrutinized it, we could see how that is the case. All right, so now I'm going to shift gears a little bit and talk about fairness in screening. So as we know, with a lot of measures of different psychological constructs, there are differences in psychometric properties across different groups of people, whether that's defined by gender, race, ethnicity, age, whatever we want to look at. So when we're looking at screening, it's important to keep in mind the fact that it may not be consistent across different groups of people, the proportion of correct results and incorrect results from screening tools. So it might be the case that a tool is more sensitive within one group. Let's say it's more sensitive among men than with women. So that would mean that the tool is not fair, and we want to ensure that our tools are fair so that we're not creating any disparities in who is receiving services. And we do think that there are disparities in the identification of mental illness. And there's quite a bit of literature at this point suggesting that people from racial and ethnic minority groups are less likely to receive mental health treatment, both in the community and in correctional settings. And a study that I did with a former graduate student a few years ago, we got some sort of publicly available data from the state of Arizona, which we chose because they have a high proportion of Latinx folks, and that's what we were interested in this particular study. And we first broke down the total prison population in Arizona by race and ethnicity. And the piece of the pie that I want you to pay closest attention to is the green chunk on the left side of the pie. So that is the proportion of Latinx folks in the entire prison population in Arizona. And then right next to that piece is Black individuals, who are that orange slice. Now, what we were interested in was whether there were any differences by race and ethnicity of people being identified with mental illness in the prison system. So our thought was, if we looked at the portion of people in the prison system who have a mental illness and looked at them by race and ethnicity, if there were no disparities, ideally the racial and ethnic breakdown of that group would mirror the racial and ethnic breakdown of the entire prison population. Whereas if there were differences by race and ethnicity, that might point to some disparities. So when we looked at just the subgroup of people in prison who had identified mental illness, we found that the proportion of Latinx folks was much smaller than what we saw in the total prison population. And if we assume that Latinx folks out in the community have a similar prevalence of mental illness as white individuals, which we believe to be true, we would expect them to have a similar rate of identification as we would see in the total prison population. And that's not what we found. We found that they were significantly less likely to be in that group of people with identified mental illness. So part of the reason why we think that this is the case, and there are multiple reasons, I don't want to oversimplify it, but we think part of it is there may be some limitations of mental health screening. So recently, my colleagues and I did a review of the literature on the evidence of mental health screens that are available to see what does the research say about the psychometric properties, in particular fairness of these tools. Our focus for this review that's in press at Psychology, Crime, and Law, it was primarily for use of these tools with Black and Latinx individuals in the justice system. And we focused on those two groups because together they make up the majority of people who are under criminal justice supervision in the US. However, for today's presentation, I also am including information about other groups as defined by gender, so I'll present information about women, as well as other racial and ethnic groups when that information is available. So I looked for evidence of utility specifically for Asian and Indigenous individuals. So the first step in our review was to determine, well, what screens are actually being used in correctional facilities. So the first place we looked was recommendations by accrediting bodies and professional organizations. So first off, we looked at the National Commission on Correctional Mental Health Care, which is an accrediting agency for correctional facilities. They indicated in their accreditation standards that screening is a part of the accreditation process, meaning that an agency had to do mental health screening to be accredited, but they did not have specific tools that they recommended for that purpose. We next look to guidelines from the American Psychiatric Association, and they have a document that's meant to serve as an addition or a supplement to the National Commission standards, specifically for psychiatrists who are working in correctional settings. And they provide much more detail about the screening process, meaning what that should look like, how the assessment should be conducted, but they also did not have specific tools that they recommended be implemented. We looked at the American Correctional Association, which is another accrediting body for correctional facilities in the United States. They also talked about screening and required screening, but again, did not have any specific tools that they recommended. We then looked at SAMHSA, the Substance Abuse and Mental Health Services Administration. They actually did have some recommendations for us. So they had a document where they recommended 3 specific screening tools. So they recommended the brief jail mental health screen, the correctional mental health screen, and the mental health screening form 3. So these were at least getting us somewhere where we knew at least some of the screens that were being recommended. In addition, we looked at some resources from the Council of State Governments that is meant to inform mental health treatment in correctional settings. They recommended the same 3 screens that SAMHSA recommended in their guidelines. So this is what we found in the accrediting bodies, the professional organizations, government agencies, et cetera. The other place that we looked was the scholarly literature. And we did a PsycInfo and Google Scholar search to see if we could identify any other screens that were being used that weren't specifically mentioned by those sources that I just talked about. So one was a meta-analysis by Martin and colleagues, and they did a meta-analysis on any screening tool for use in correctional settings that had more than one study with psychometric properties of that screen being presented, so more than one validation study. And we found that they also talked about the brief jail mental health screen in addition to the correctional mental health screen. So those were 2 that we already knew about. They also mentioned the referral decision scale. The referral decision scale was actually the parent tool to the brief jail mental health screening tool. So we determined that we were going to review that sort of in conjunction with the brief jail mental health screening tool. And then Martin and colleagues also mentioned 2 other tools that were developed for use in other countries. So we did not review them further. So the jail screening assessment tool has some validation data, but that tool was developed for use in Canada. And as you can guess, the England mental health screen was developed for use in England. So that was not relevant to our purposes. So we did not include those in our review. The other main resource that we found is a number of studies assessing the K6 or the Kessler-6 screening tool. This was recommended specifically for use in correction settings by Schwartz and LaRegio way back in 2005. And Kubiak and colleagues had a number of articles where they published results of the utility of the K6 in correction settings. So once we did this sort of preliminary scan to see what tools are actually being used, we narrowed that down to the 3 that SAMHSA and the Council of State Governments recommended, in addition to the K6, and we performed searches of the literature, both in PsycInfo and Google Scholar, to see what data we could actually find on the fairness of these tools. And before I talk about the results, I want to be clear about how we define fairness. So there's a publication by the APA, the Psychology APA, and other organizations that is the Standards for Educational and Psychological Testing. And this is a guide that talks about the psychometric characteristics that should be present in psychological tests. And it's not meant to be used as sort of a checklist because different tools have different purposes. So for screening, in terms of a tool being fair, the primary thing that would be relevant is criterion validity. So criterion validity for a mental health screening tool is the extent to which it is identifying mental illness. So really we're looking at sensitivity. Fairness would mean that the tool has similar sensitivity across diverse groups of people, that it works equally well in identifying mental illness across all different types of groups that we see in correctional settings. Another type of fairness beyond just the psychometric properties has to do with accessibility. And a key part of accessibility is making sure that the tool is available in languages that are commonly spoken by people in that context. And we define this in a very basic way as just having the availability of a Spanish translation, given the high proportion of Latinx folks who either speak Spanish predominantly or that is their preferred language. So just as a very basic test of fairness, we looked at these two criteria, the criterion validity and the availability of a Spanish translation across the 4 tools that I mentioned. So let me tell you about what we found when we looked at the literature on each of these tools. So first off, I'll talk about the brief jail mental health screen. So the brief jail mental health screen is a tool that gets at both symptoms and treatment history. So there's a series of questions about symptoms. There's an example on the screen. Have there currently been a few weeks when you felt like you were useless or sinful? That's an actual item from the tool. It also has 2 items about treatment history. An example of that is, have you ever been in a hospital for emotional or mental health problems? The format, it's meant to be delivered as a very structured interview, meaning a staff member is meant to ask the questions directly as they're written to the person being assessed. It has 8 items. All of the 8 items are scored on a yes or no format. This tool was developed specifically for use in correctional settings, primarily jails, as you can tell by the name of the tool. So what did we find about the utility of the brief jail mental health screen? So first off, we found that the tool has lower sensitivity for women than for men. They found that the sensitivity was only 0.46, which is pretty low sensitivity for women. They initially tried coming up with a revised tool that would be more sensitive for women, and the revised tool didn't perform even as well as the existing tool, so the revision kind of went away. I was not able to locate any criterion validity, meaning sensitivity or specificity information by race or ethnicity. However, what we did find is that across a couple of studies, both Black and Latinx individuals were less likely to score above the cutoff compared to white individuals, meaning that those folks were less likely to be identified for further mental health assessment. And it wasn't clear whether it was that they were less likely to answer yes to the symptom items or the past treatment items. It seemed to be a combination of both of them. There was no data on any other groups such as Asian or Native American people with the BJ-MHS. In terms of a Spanish version, there is a Spanish version available on the developer's website, but they note that there is no research on the validity of this Spanish translation. All right, so now I'll shift gears and talk about the correctional mental health screen. This tool actually has 2 separate versions, one for men and one for women. It also, like the BJ-MHS, measures both symptoms and treatment history. It has it's a bit longer. So the version for men is 12 items, whereas the version for women is 8 items. It also is a structured interview meant to be administered by staff to an individual being assessed. Also, yes or no questions. And that makes sense because this tool came out of concerns about the limited utility of the BJMHS, so that it's very similar in structure. It also was developed specifically for use in correctional populations. In terms of evidence of utility for this tool, we found that it had slightly lower sensitivity in terms if we're comparing the tool for women to the tool for men, but it wasn't a huge difference like what we saw with the BJMHS. We did see preliminary promising evidence among Black men and Black women. And when I say preliminary, it demonstrated adequate sensitivity and specificity, but the sample sizes were very low. I think there was only 28 Black women and 69 Black men in that study. So even though it had good sensitivity, given the small sample size, that's not really a reliable finding. There was no information about the utility of the tool with any other racial or ethnic groups, even though they had attempted to recruit enough Latinx individuals to do separate analyses. They didn't have enough of people in that group to do separate analyses there. There is no Spanish version of this tool. Next, the mental health screening form 3. This is another tool that gets at both symptoms and treatment history, so kind of similar in terms of content to the previous 2 tools. This one is a little bit different though in terms of its format. So this is a semi-structured interview, meaning it's not meant to be read exactly how it's written on the form itself. It's also a little bit longer than the previous tools at 18 items, meaning it takes a little bit longer to administer. This one was not specifically developed for correction settings. It was actually developed for use in community settings. In particular, it was meant to assess mental health symptoms in substance abuse treatment settings. And we actually found pretty limited research on this tool. So it was more sensitive for women than men, but the sample was very small. And we were unable to locate any evidence by race or ethnicity in terms of criterion validity. There is a Spanish translation of this tool, but there's no data on the validity of that tool. And then finally, the K6. So the K6, unlike the other tools that I've covered, only assesses symptoms. And all of those symptoms are asked within the context of the last 30 days. So during the last 30 days, how often did you feel hopeless? During the last 30 days, how often did you feel restless or fidgety? This is a self-report, so it's meant to be done on pencil and paper by the person rather than being asked by a staff member. It's 6 items, and they're asked instead of yes or no, like the other tools, the items are assessed on a 5-point scale, meaning how much the person felt that symptom. This tool was developed for use in community settings, primarily in epidemiological research. So there's tons of research on this tool specifically in community settings, and there's just a couple of the citations down at the bottom of my slide. So there's a ton of research seeing this tool is very promising in the community, and that's what led Swartz and Larigio back in 2005 to say, this is a promising tool for use in corrections. And since then, it's been tested out in corrections a little bit. So what we found, a study I did where we tried using this tool in a probation setting, we found it was a little bit more sensitive for women than men. The sensitivity finding for men was not really adequate in that setting. There's no data that we could find in terms of criterion validity in correction settings by race or ethnicity. We did find that, like we found with the brief jail mental health screen, both Black and Latinx individuals are less likely to screen in those settings. So that's something that needs to be explored further. There is a lot of fairness data for this tool in community settings. And in the community, we find really promising sensitivity and specificity for Latinx, Black, and Asian individuals. I did not find any research looking at using this tool with Native American or any other racial or ethnic groups. But I will note that it's important that we test these tools in correction settings rather than relying on evidence from the community, because there are just different reasons why people might be more or less willing to report symptoms in a correction setting. So even though it's promising in the community, that's not kind of the endpoint for evaluating that. There is a Spanish version of this tool, and there are multiple validation studies, all of which were done in the community, but it seems to be promising. So to kind of sum up what we found, there's not enough research in terms of fairness of these tools in correction settings. It's really important that we test these tools in the setting where we would like to use them. And there's simply not enough research on any of these tools in correction settings for us to be able to say this tool works adequately or this tool doesn't work adequately across diverse populations. The other index that we looked at in terms of accessibility is looking at whether there's a Spanish version of the tool, and we found that typically when there was a Spanish version, it was unvalidated. The other thing I would say about that is when there were Spanish translations, they were typically literal translations of the tools, and best practices in terms of translating measures is not that we do literal translations, because sometimes things don't carry over in meaning. It's important that we do an iterative process of exploring the meanings of these words and the items with members of the community that we're hoping to use the tool with, and not just sending it to a professional translator to put it into the second language. So in terms of research directions, and I know y'all are in the clinical world, we don't know as researchers what tools are actually being implemented. So we relied on what was publicly available out on the internet and in these scholarly databases to determine what tools are being used. But I happen to know, because I work in Texas, that Texas has its own measure that they use in all of the jails. And I didn't see that mentioned once in any of the literature or research that we looked at. So it's possible there are lots of other tools being used and we just don't know about them. So we as researchers to do a good job of validating these tools need to know which tools are being used. And once we do that, we need to do research to examine the criterion validity across diverse groups of people who are involved in our criminal legal system to ensure that we're not disadvantaging anyone against receiving mental health treatment when they're in a correctional institution. And importantly, we need to really examine these Spanish translations, and it's possible that they're not adequate, and it's maybe the case that we need to start from scratch and create tools that are specifically tailored for Spanish-speaking individuals in corrections. So now I'm going to shift gears to what is likely more relevant for many of you is clinical considerations. So first off, a couple of thoughts that we came up with in terms of choosing the screens. So first off, I mentioned at the very beginning of the presentation that it's important to specifically measure risk of self-harm, and none of the tools that we assessed actually measured that. So they measured things like distress and symptoms, but not self-harm specifically. So it's important that whatever mental health screen is used, it's coupled with a screen that is specifically meant to assess self-harm risk. Given the findings that we did see in terms of the tools having less sensitivity for many groups of folks, it may be advisable to combine more than one tool. And consider an individual for further assessment if they screen in on one or both of them. In addition, it's possible that facilities could experiment with lower cutoff scores. So we usually find that there's a good proportion of people who are screening in. Typically, we want to see about 30% of people screening in on whatever tool is being used, and that proportion of people receive further evaluation. If a tool is implemented in a facility and only 10% of people are screening in, that's maybe an indication that we should try lowering the cutoff score. But I say that with caution, that it really should be coupled with some sort of analysis or data to ensure that we're making good decisions for folks. And then in terms of assessment, so screening is just the first step, right? So we screen folks, we see, are they likely someone who has a mental illness or likely not, and then we give them an assessment. It's important that those assessments in these contexts are doing an adequate job of identifying mental illness in these settings. So we recommend that beyond just focusing on what these screening tools say, that we incorporate things like behavioral observation to look for, maybe if someone denies symptoms at intake, but they're behaving in such a way that we feel like, oh, that person is depressed, then that should initiate further assessment. It may also be useful to expand screening beyond just the intake to sort of an ongoing basis to continually check in on folks to see if their symptoms are increasing or decreasing over time so that we can keep an eye on that. It's extremely important that through this, through the screening, but more so through clinical assessment, that we're taking into account differences in culture that lead to differences in how people express mental illness, how it may be presented, as well as any of the contextual factors that may promote or inhibit people's willingness to disclose any mental health concerns that they may be having, and ensure that staff are trained in those differences and are culturally competent. And then finally, it's important that people who are predominantly Spanish speakers or predominantly speak another language are assessed appropriately. And it was very concerning that we found that many of these tools just were not available in any other languages, and it's not clear to us how that screening is taking place. So it's important that beyond just translating our tools, that we ensure that there is someone who is able to communicate in the individual's language to ensure appropriate assessment. Okay, I have some references, and again, the slides will be available to folks after the presentation. I want to thank my research lab, and I'll briefly flash the QR code up there if you're interested in learning more about my research, or if you're interested in connecting with me. And I will leave it there, and I will let Anthony handle any questions.
All right, thanks so much, Dr. Eno Louden, Jennifer, for a very thorough talk there. We already do have indeed a number of questions here. I encourage everybody here, if you haven't looked at the links for your CEU credits, make sure you check the chat box for those, make sure it works for you and that you're able to save them. We do have questions already, but you're also feel free to continue entering questions. We'll ask a couple of these here. Somebody wanted to clarify that typically in practice, are these screens done most common by mental health staff, or is it other kinds of non-mental health trained staff?
I can give my impression based on the facilities that I'm familiar with, but I think that should also be part of a wider survey of correctional practices, because I think the short answer is we don't really know. I know, for example, in a jail that I work with, it is sort of like a medical technician type of person who does the mental health screening in conjunction with a number of other medical questions. So it's kind of embedded there. It's not necessarily a person trained in mental health specifically. I know in some other facilities, it's just done by a general sort of correctional staff member. And again, not necessarily someone with training. I think the fact that some of the measures, particularly the ones that were developed for use in corrections, are so structured is for that reason, that they're meant to be administered by people who probably don't have any training in mental health or sort of interviewing skills. But again, we're not sure. And I think it's important that we understand that a little bit better.
Absolutely. Thank you for that. Somebody asked a question that relates to diversity specific issues here, as you've discussed. And they noted for measures such as the CMHS that might have different versions for men versus women, what considerations might there be for screening individuals that do not identify as man or woman?
Yeah, that's a great question. And honestly, there's no first of all, there's no research on that to kind of inform best practices. I would say just from my experience, in terms of, how correctional staff typically would respond to an individual who was non-binary or non-conforming, they would either they might make the person choose one or the other, or if the person didn't want to choose, they might choose what they thought was more appropriate based on that person's appearance. I don't think that's the appropriate response. But I think that's an area where we as a field really have not considered how gender expression beyond the typical binary might affect mental health assessment in this way.
Fair enough. We have a couple of questions that sort of about the pinpointing different correctional kind of environments. So one question is, any information about how performance of these measures differ in prisons versus jails?
Yeah, so the most of the research on the brief jail mental health screen is in jails. Most of the research on the correctional mental health screen, I believe, is in prisons. The K6 research is primarily in jails, to my understanding. So it really depends on the tool, because they really were kind of developed or identified or studied kind of in these really specific contexts. I've not really seen any comparisons of one tool across multiple settings. And I think it probably is a good idea that we would have different tools for jail versus prison, given that there's different needs for those populations. So someone coming into a jail is more likely to be in acute distress. There's a big risk of self-harm, and we need to identify that as quickly as possible. And it's likely that that person may not be in the facility very long, and we need to kind of do the screen within that context. Whereas someone who's being brought into a prison setting, it's usually with the idea that they're going to be there for a while, and our questions might be different in terms of informing long-term treatment for that individual. So I think it's good that we have different tools, and we should further develop them in these specific settings to make sure that they're meeting the needs of those contexts.
Excellent. Thank you for that. Somewhat related, someone noted you listed accrediting bodies that provide guidance for correctional facilities. Do you know of any that look at mental health practices in ICE detention facilities, Immigration and Customs?
Oh, that's a really good question. I haven't looked into that, and I think that's crucially important. I think that's, once we're done today, that's probably going to go on my to-do list, but I think that is extremely important. We didn't look at that, but yeah, thank you to whoever brought that question up, because that's extremely important.
Excellent. we have a prosecutor who is asking, in the state in which I work as a prosecutor, we're seeing more than a few inmates using mental health complaints whose illnesses severity appears to be less than what it appeared in self-report. And when we dig into their clinical records, seems to be to set up delays in court, like competency restoration services. Is there any low-hanging fruit you would recommend to correctional staff who often have limited time and resources themselves to screen out that kind of dissimulation?
I think that when I don't know that there's any sort of mechanism within the screening tool itself to weed that out. I think for a 6-item or 8-item or 12-item scale, if someone is trying to malinger, then they're just going to say yes to everything or say 5 out of 5 to everything. And that, that's something that is just going to have to be weeded out through further assessment. I think where it really comes in terms of identifying those folks is just ensuring that the clinician who's conducting the assessment that happens after the screen is trained in how to pick up on those issues, right? So oftentimes when people are malingering, they tend to not do a great job at it, where if you ask them about a bunch of symptoms, they're going to say yes to everything, but the symptoms that they're describing don't match up with their behavior, or the symptoms are contradictory, or they're just saying every symptom. It's kind of like going to the doctor and saying, well, I have a headache and also a stomach ache and also my back hurts and also I have insomnia, and these are just kind of random things. A lot of times that's how it comes across. So I think just making sure that our staff have the training and also the time that they need at that assessment stage to make sure that we're doing an adequate job, both so we could, potentially identify people who are malingering, but also taking into account that maybe that person does have a mental health issue that is an atypical presentation of it, and making sure that we're making the right decision for them.
Yeah, and I think from a clinical perspective, I mean, the very first things you talked about here when thinking about sensitivity and specificity, there are very different stakes of being wrong in different directions when you're talking about assessing needs and risk for self-harm. And there's certain directions that, at least from a clinical perspective, we tend to prefer to err on one side.
Exactly. I mean, if the consequence of having a false positive is it takes up too much of our time, but the consequence of a false negative is someone didn't get intervention and they're at risk of hurting themselves, I feel like that is as frustrating as those false positives might be, the false negatives are potentially more problematic for the agency in the long run.
Certainly. And then one more quick question. Someone wanted to clarify, and this might have been at the end about a particular issue, but I guess I'll broaden it up, that a lot of the information you presented, a lot of it centers on risk of self-harm. Is there anything here about potential for risk for harm to others?
I don't feel like that's really been part of the conversation in terms of mental health screening. I think in terms of risk of self-harm, we typically look more to history of self-harm, or history of harm to other people. That would probably be covered more likely in a criminogenic risk assessment that typically most facilities do, at least prisons, when they're making decisions about security level or placement decisions like that. But no, I haven't really seen that as part of the conversation in the mental health screening.
Well, fair enough. Thank you so much, Dr. Louden, Jennifer, for all of that very helpful information and looking at some of these very specific instruments that we might be able to use together in isolation, however they might work, and thinking about the different contexts of the specific clientele we work with here. That wraps up this week's Law and Mental Health series. Stay tuned next week when I will be discussing different factors inherent to forensic evaluations that contribute to bias. Until then, we hope that you have a fantastic rest of the week, and we hope to see you again.